Thank you very much, Joshua. Thank you very much for inviting me to chair this very interesting session. And thank you all for coming bright and early for this, what I think is promising to be a very, very interesting and exciting conference and very exciting discussion, definitely, this morning. So my name is Angeliki Kerasidou. I'm an associate professor in bioethics at the Ethox Centre here in Oxford. And I used to be actually a student. I did my master's and my DPhil student here at Harris Manchester. So it's actually quite lovely to be back in my old college. So how the morning is going to go, we have two papers. Each paper will be half an hour, so we have two presenters, and I will introduce them in turn as they come to speak. And then after the two presenters, which each paper, as I said, will be half an hour, we're going to have a 10-minute response, and then we'll have 20 minutes for discussion. So I expect all of you to be making notes and writing questions down as the speakers speak, and be ready to put your hands up at the end. And with no further ado, I'd like to introduce our first speaker for today is David Albert Jones, Director of the Anscombe Bioethics Centre here in Oxford since 2010, and Research Fellow in Bioethics at Blackfriars Hall. He's also Professor of Bioethics at St. Mary's University in Twickenham. So, David, over to you.
Thank you. And also, well, I'm sure lots of people here have many hats. And also, I'm Vice Chair for the Ministry of Defence Research Ethics Committee. And I mention that because it is actually relevant to my first slide. This paper started Life, if they have Life papers, as a prospective journal article. But I never got round to revising it in the light of reviewer comments, and then this conference turned up, and it fitted exactly to this conference, so it's been redirected. But there's much more material that I wanted to talk about, that I'm still interested to talk about, than could fit in half an hour, and so that will wait for the book, which I hope will come out. We had a conversation about hope yesterday. This is the kind of thing that we hope for, which is a temporal thing, but a reasonable amount of the arduous good, and also an arduous good which one works on together with a shared understanding of the good and a contribution one hopes to the common good. So the title of the talk in the abstracts is COVID-19 and the Undoing of Character, Moral Injury, Moral Distress, and Violations of Conscience During a Pandemic. I'm going to talk more about the subtitle and the title, and essentially I'm going to look at just three concepts: the concept of moral injury, the concept of moral distress, and the concept of conscience, and how they might relate to one another. But I'm doing so in a context of the pandemic. So the teasing out of the application to the pandemic is something for later, in a way. Let's see. Right, so I'm starting with, this is an editorial from 2020 in a journal called Occupational Medicine. By Williamson, Murphy, and Greenberg, who are three members of the King's Centre for Military Medicine. So this is relevant. That's King's College London. So King's College London have a centre which specialises in military medicine in relation to the military, and they wrote this in this editorial, which was called COVID-19 and the experiences of moral injury in frontline key workers, and they say, quote, "Much of the research in moral injury at this stage has been carried out on military personnel and veterans." That statement says much more about the authors than it does about the type, but nevertheless, that's where they start, 2020. Much of the research into moral injury at this stage has been carried out on military personnel and veterans. However, several potential risk factors for moral injury have been identified that may be applicable to other professions during the COVID-19 pandemic. So they take a concept which for them is a concept within military medicine, that's their speciality, and they say, actually the pandemic, like other catastrophes, has some things in common with warfare, and some of the things that we see in relation to warfare might also be there. And the examples they give are the requirement of healthcare staff to self-quarantine when colleagues are being overwhelmed. So just at the time when resources are most stretched and you see your colleagues, going under, and you really want to help, you have to self-quarantine because those are the rules. But it's very frustrating. The withholding of potentially beneficial life-saving treatment due to limited equipment. So rationing, which is a ubiquitous part of healthcare, but has a particular hard edge in emergency situations, and the difficulty of performing duties adequately due to constraints of personal protective equipment. I'm not really convinced that any of these are good examples of moral injury, but these are the examples that they give, and the last one I will come back to in a slightly different form. So where does this tradition that they situate, that Greenberg and co. situate themselves in, begin? Well, it begins really before the First World War, but particularly after the First World War, reflecting on shell shock and the psychological harm done to soldiers from shell shock was. It made people more interested in trauma generally, and this developed into the concept of PTSD, of post-traumatic stress disorder. I was surprised to find that PTSD only found its way into the DSM. The DSM is the Diagnostic and Statistical Manual of Mental Illness, which is the kind of Bible of psychiatry in the United States, but there's nothing quite like it in any other country, so psychiatrists all over the world look to the DSM. It was only in the third edition of the DSM in 1987 that PTSD got in, which surprises me, but there you go. But it's there in the DSM, and PTSD is defined in part because of its cause. PTSD doesn't reflect a weakness that an individual has in coping with stressful situations. It reflects an ordinary person that has been exposed to extreme and catastrophic stresses, which has had a certain impact. So you understand it not by the predisposition of the person, but by by what they have been exposed to. Hence the trauma for PTSD, and it's a well-recognised syndrome. So now to moral injury. So in the 1990s, PTSD was well recognised, well understood by psychiatrists working with veterans. But there's a psychiatrist called Jonathan Shea, and he thought there was something which was missing from the definition. In that it abstracted from making any moral judgments about what had happened, either about the causes or the effects of the problem that people had. Whereas he thought in at least some cases, the morals was what it was about, and in particular in relation to betrayal. So he was very interested in betrayal by leadership, because he thought that what a PTSD in relation to the military missed was that war is essentially a moral endeavour. That is to say, it is it's characterised by commitments to certain goods which give the rationale for the whole project. And when those goods are undermined somehow, then you have effects which are due to the nature of warfare and the nature of soldiering. And so it's one thing for people to see their their comrades killed and to be exposed to very traumatic situations. But if they think they shouldn't be there, and they think that they're doing more harm than good, and that they've been put in danger because of decisions which are either thoughtless or vicious, that they have been undermined by their military leaders and behind that their political leaders, then the ability to process or make sense of this experience, but also not only experience, these actions of theirs, is itself undermined. And therefore you get an undermining of character, hence this notion of the undoing of character. So he wrote a book called Achilles in Vietnam, Combat, Trauma and the Undoing of Character. And then a few years later, Odysseus in America, Combat, Trauma and the Trials of Homecoming. And in both cases, he looked to